Session is sponsored by Novartis, and I invite our speaker, Dr. Renu Mishra, medical oncologist from Udaipur, and she'll be talking on the topic personalized therapy to further improve outcomes in patients with BRAF mutated NSCLC. Over to you, ma'am.
Good evening, everyone. Today I would talk about personalized therapy to further improve the outcomes with BRAF mutated non-small cell metastatic NSCLC cases. So my objectives would be to cover the understanding the role of BRAF in metastatic NSCLC, gaining awareness of BRAF testing methods, and diagnosis of BRAF positive NSCLC. To review the clinical data of dabrafenib and trametinib in advanced non-small cell lung cancer. So first the introduction about the BRAF pathway, that is the MAPK pathway. So MAPK pathway is the mitogen activated protein kinase pathway. It regulates the cell signaling from transmembrane growth factors leading to cell proliferation. So any oncogenic mutation in the MAP pathway, including the BRAF kinase mutation, they have been reported in number of human cancers, and lung cancer is one of them. BRAF mutation result in constitutive BRAF activation and thus the uncontrolled signaling via the MAPK pathway, which we can see in this picture, the KRAS, BRAF, MEK, MAPK. This pathway is mutated in a lot of cancers. Melanoma, 50 to 60% cases we see BRAF mutation, and the data from melanoma has been extrapolated and put into use in colorectal and lung cancer as well. So BRAF mutation in NSCLC, BRAF mutation occur in around 1 to 4% of non-small cell adenocarcinomas, and BRAF mutation typically do not overlap with other mutations, that is the ALKRAS, VEGP2. In contrast to other oncogenic driver mutations, the key patient characteristics are not very well characterized with BRAF, like it does not correlate with the age, sex, stage or smoking status. However, there has been small contradictory studies saying they are more common in females or smokers, but there is no conclusion about it so far. Although V600E is the most common BRAF mutation, occurring in 50 to 70% of the BRAF positive cases, other mutations are also there. And the diversity has important implication because the strategy, the targeted treatment we have is for BRAF V600 mutation. There are various other mutations in the BRAF which we can see here. So what has been seen is that patient with BRAF V600E mutation, they have a shorter median disease-free survival and overall survival than patients without these mutations. That is, these tumors are more aggressive and patients have a worse outcome, especially if they are treated with conventional platinum-based chemotherapy. Outcome in patients with BRAF V600E mutations versus those with wild type, if we compare, if we look at this table here, the clinical outcome we can see with a BRAF positive patient, the overall response rate with the first line platinum therapy is just 29%, and the median PFS is 4.1 months, median OS is 10.8 months. So treatment still remains suboptimal for patients with BRAF positive, BRAF V600E positive NSCLC. So approximately 1/3 of patients remain untreated, that is 33% have been found to just been given best supportive care. 52% patients have been given platinum based doublet chemotherapy, and but what has been seen is that as with all the other driver mutation positive lung cancers, this also shows a better survival if we treat it with the targeted therapy. So patient with non-squamous NSCLC without mutated ALK, ROS currently receive chemotherapy or immunotherapy, and followed by, as we have discussed, followed by the maintenance, and if the PS is not, if PS is 3 or 4, then best supportive care. But if we choose broad molecular profiling, that is, we include BRAF testing at the onset, then we can identify these patients at the onset and treat them. So current consensus guide us to include BRAF along with EGFR and ALCross, as it is stated in NCCN now, that we should include BRAF testing, and so a broader panel through NGS testing should be done. So upfront BRAF testing is needed so as we can quickly identify and treat these patients. And there is no clear clinical risk factors like age, sex or smoking history that we can choose such patients. So now looking at some of the data for dabrafenib and trametinib combination. So dabrafenib and trametinib, they target different kinases in the MAPK pathway. Dabrafenib it is a selective inhibitor of RAF kinase, while trametinib is a highly selective inhibitor of MEK1 and 2 kinase activity. And this drug is the combination of dabrafenib and trametinib is DCGI approved for advanced non-small cell lung cancer with a BRAF V600E mutation. So what is the rationale of this combination? Why do we use a doublet? So as it was seen in the studies in melanoma, that using a single drug can lead to resistance and the activity of single drug is less. So double drug delays resistance, and they both act synergistically in BRAF positive cases. So the approval for this drug has come from a phase 2 study, and this study included patients with stage 4 BRAF V600E positive patients with the PS of 0 to 2. They had no treatment with BRAF inhibitors, and patients with more than 1 centimeter brain mets were excluded in this study. This study had 3 cohorts. Cohort A and B had pre-treated patient. Cohort A received monotherapy with dabrafenib, while cohort B, they received dabrafenib and trametinib combination, while cohort C, this had treatment naive patients and they received BRAF directed therapy first line. So the primary endpoint was overall response rate, and the secondary endpoints were PFS, DOR, OS, safety, and the population pharmacokinetics. So what was seen in this was the cohort A, where the median age was 66, male-female ratio was they were equally balanced, whites were the majority of the patient, and 2/3 of the patient were current or former smokers, and nearly all the patients had adenocarcinoma histology, and almost half the patients were in the second line or beyond. In the cohort B, this group received the doublet and they were also treated previously. These all patients had adenocarcinoma, and 3/4 were current or former smokers, and 1/3 of patients had received more than 2 previous lines of chemotherapy. Now coming to cohort C, these were treatment naive patients. They were being given BRAF directed therapy first line, and all these patients had adenocarcinoma histology. And as we discussed the primary endpoint, this is again showing the trial features. So now this is the assessment for the cohort A. I'll show the comparative slide directly. So this is the final efficacy summary, where dabrafenib and trametinib was more effective than dabrafenib alone in previously treated patients. So cohort A patient, where monotherapy was given, the overall response rate was 33%, while when the combination was given, this response rate improved to 63%, and in the treatment naive patients, previously untreated patient, there the overall response rate was 64%. The disease control rate was 75% in the cohort C, and the PFS was maximum with treatment naive patient, that was 10.9 months. So overall we can see these patients fared far better when they were treatment naive and started directly on BRAF directed therapy. So coming to the adverse events, so it was observed pyrexia as the most common side effect, even in the monotherapy arm and in the combination arm. So, but however, most of the adverse events were in the grade 1 and grade 2. There were very few patients who had to live, around 14% who had to discontinue the treatment because of adverse events. So pyrexia was the most common adverse event, that was 46%. However, only 2% had grade 3 pyrexia. So in both of them. So how do we manage pyrexia if it comes across in our clinical practice? So we have to interrupt the treatment if temperature is more than 38.5, and we can interrupt dabrafenib, and trametinib can be continued. However, some studies say that we should discontinue both the drugs, and we can initiate antipyretics like ibuprofen or paracetamol, and if the patient still doesn't respond, then we can start oral steroids. So the pyrexia management is first we have to look for any infection or hypersensitivity, and all the lab work for that should be done. And the first thing we have to manage is hydration. Patient should be hydrated very well if in the event of any pyrexia. The antipyretics we should start, interrupt dabrafenib, and once pyrexia resolves in the first event, we can restart dabrafenib at the same dose. And if fever is associated with dehydration or renal insufficiency or hypotension, like any complication, then we have to reduce the dose of dabrafenib. In the second event, we treat as same for first event, but we consider steroids. And in a subsequent event, if it happens beyond second, then we should interrupt dabrafenib and restart. Whenever we restart, it should be at a reduced one level reduced dose. So what is the starting dose? The preferred starting dose is 75 mg, 2 tablets, that is 150 mg of dabrafenib and 2 mg OD of trametinib. The first dose reduction is 100 mg BD, and for trametinib it is 1.5. Second is 75, and third is 50. And if patient is not able to tolerate 50, it is preferable to discontinue the drug. And this drug, they should be taken without food or 2 hours after a meal. So to sum it up, the safety profile was manageable and pretty much similar to what the melanoma study showed. The most common adverse events were pyrexia and GI related toxicity and skin reactions. And pyrexia was the most frequently observed adverse event in all cohorts, and it is manageable by the pyrexia treatment protocol we just discussed. Thank you.